Yes, students, you're welcome to this session. Student Rokina, and I will be taking you through this parameters. So let's start by looking at the different types of the how it comes about and how it can be managed. So let us now dwell deep into. So let's start with the insulins. So when we talk about insulins, when we were talking about diabetes and what it is, we looked at the fact that diabetes is brought uh, because of insufficiency of the cells are having that resistant insulin, so they cannot take it up, and as a result, the glucose that is in the blood circulation will not be able to be taken by the children. Or to treat that problem, we need to use insulin. So we when we are using the insulin will substitute the body make. But why we say that these insulins substitute the endogenous insulin. So the endogenous insulin is the one that our bodies make. These insulins effects mimic the normal insulin body. So that means that they will be able to enable the glucose to be taken up by the tissues. So they also restore the diabetic patient's ability to metabolize carbohydrates, fats, and the proteins so that the body can be able to produce energy. Then also to store the glucose in the liver and convert glycogen to fat stores in the body. So these are some of the benefits that the insulins can bring to the body of a diabetic patient. So let's talk about human insulin. So the human insulin is the one that is derived from recombinant DNA technologies. So technology can be used to make sure human insulin is generated, so it can be used for treating someone with diabetes. So this human insulin is produced by bacteria and yeast using recombinant insulin. So the goal is to achieve tight glucose control to reduce the incidence of long-term complications. Let's look at types of insulin. We have the short-acting insulin, intermediate insulin, and long-acting insulin. So short-acting insulin, this is administered via IV infusion for rapid onset, especially for diabetic ketoacidosis. So we said that diabetic ketoacidosis is a situation whereby the body is now not able to use the glucose produced by the carbohydrates. So as a result, it results into metabolizing the proteins and fats to make sure that they produce energy. So when the fats are metabolized, they produce ketones and the acidosis in the body. So these ones, when they are in high amounts, the person ends up with the diabetic ketoacidosis, and as a result, the person can even go into shock. So or into coma. So in such situations where the body is now burning down the fats to provide energy to the body, that is when the person is termed as being in a state of diabetic ketoacidosis. So this is the situation where we need to give insulin immediately, that will act very fast to make sure that the situation is reversed, and this is a situation where the short acting insulin is given. Why? Because for it yields rapid results, very fast results, and it can be given through IV. Then we have intermediate acting insulin. So for this one is characterized by cloudy appearance due to zinc insulin crystals that are found in them. So the zinc insulin crystals and the protamine sulfate in buffered water suspension are the ones that give the cloudy appearance. So for the intermediate acting is slower onset and prolonged duration compared to the endogenous insulin. Then let's look at the long acting. The long acting insulin provides a constant level of insulin, which is known as the basal insulin. This one is constant throughout, can take long. When it is taken like once in a day, depending on how it has been prescribed, whether once in a day or twice in a day, it is released in bits to make sure that there is constant supply of insulin throughout the day. So the examples under long-acting insulins include Levemir, which can also be known as Detemir, and this one is usually higher doses can given once or can be given in lower doses twice a day. That is 12 hours apart. So can either be given higher doses once in a day in 24 hours, or can be given in lower doses 12 hours apart. So the other one is insulin glargine. So this one has a concentration of up to 300 units of insulin. So what are the dosing strategies? The dosing strategies, let us look at sliding scale insulin dosing. So this is a kind of dosing that is adjusted based on the amount of glucose that is in the blood circulation, and in most cases this one is done when we are administering the short acting insulin. So the dose is adjusted based on how much glucose is in circulation, and it needs to be taken up into the tissues. So this one is commonly used in hospitalized diabetic patients or those on total parenteral nutrition, which can be abbreviated as TPN, or enteral tube feedings, like patients who are on NG tube. Then patients on steroids may require insulin due to increased glucose levels. Let's look at the basal bolus insulin dosing. So the basal is the one that we have already talked about, where there's the release of glucose is long. So then the bolus is the one that is administered through injection. So the basal bolus insulin dosing is a method of managing blood glucose levels in people without diabetes. It involves insulin once or twice a day to keep the blood glucose stable between meals and overnight. And taking a rapid a rapid acting insulin or bolus before each meal or snack to cover the rise in blood glucose from food intake. So there is always that allowance to make sure that uh, even if the person eats and the glucose levels rise, it is covered for, so that the person does not go into hyperglycemia. So basobolus insulin dosing aims to mimic the natural pattern of insulin secretion by the pancreas in people without diabetes. So this kind of dosing is used to make sure that the body the amount of insulin in the body is kept constant, kept stable throughout, like for someone who is not having diabetes, even if the person is diabetic. So this kind of dosing is preferred in people who are throughout the period. Then the bolus insulin delivered is as needed by the body. Basal insulin is in most cases the long acting kind of insulin that the body can be given. For instance, the insulin glargine. Then the bolus insulin, this one is the fast acting insulin. That is why we said that it is given when the body or as the body requires it. When the body has lots of glucose in circulation that needs to be taken into the tissues, then definitely the right kind of dosing will be the bolus insulin dosing. Let's look at the oral hypoglycemic drugs. So these drugs include the following. We have the biguanide, sulfonylureas, glanides, thiazolidinones. Then we have alpha glucosidase inhibitors. Then we have dipeptidyl peptidase 4 inhibitors. So let's look at oral antidiabetic drugs for type 2 diabetes. The treatment approach. Careful monitoring of blood glucose levels is very important. Single or multi-drug therapy is recommended. Treatment of associated comorbid conditions like high cholesterol and hypertension is also very considered in this kind of treatment. So new onset type 2 diabetes mellitus can be treated as follows. The person can be encouraged to change the lifestyle. So this is referred to as lifestyle interventions. Like for instance, someone who was smoking heavily and someone who was taking alcohol can be advised to pull away from that to make sure that he improves his lifestyle. Then the other one is oral biguanide drugs such as the metformin can also be used in patients who have new onset of diabetes type 2. So let us look at how can the biguanides be used. One example of them is the metformin. So the mechanism of action, These biguanides decrease glucose production in the liver. They also decrease intestinal absorption of glucose. So the aim here is to make sure that the glucose that is in blood circulation is as minimal as possible. So what this kind of medication does is to make sure that the glucose that is produced in the liver is decreased, is minimized. Then the glucose that is absorbed by the intestines is also minimized. Then they will increase the uptake of glucose in the intestines, I mean in the tissues. Then these kind of drugs also do not increase insulin secretion in the pancreas. So the issue to do with insulin secretion is not tempered with, is left the way it is. So what these drugs do is they play around with the liver. The liver has to decrease the processing of glucose. The intestines have to decrease the absorption of glucose. So the most of the glucose has to be taken into the tissues. So to make sure that the tissues take in enough of the glucose, but they do not interfere with anything to do with production of the insulin in the pancreas. So the adverse effects of biguanides or the metformin, primarily there will be GI effects. So if the GI effects are being experienced, the patient is advised to take the medication with food to make sure that they are overcome. Then rare risk of lactic acidosis can also occur. Then one thing to be noted is they do not cause hypoglycemia. They can never cause hypoglycemia. What are the contraindications? The contraindications include the following: renal disease or dysfunction. So if the person is having renal dysfunction or renal disease, then the person is not supposed to take any of the biguanides. If the person has metabolic acidosis, hepatic disease, heart failure, increase the risk for lactic acidosis, the person, due to increase the risk of lactic acidosis, we don't have to give the person this kind of drugs. What are the interactions? The drug interactions for biguanides include the following: iodine containing contrast media. Any iodine containing contrast media should not be administered together with the biguanides because they will interfere with their functioning. So let us look at sulfonyl ureas. So the sulfonylureas, for them, their mechanism of action is as follows. They stimulate insulin secretion from the beta cells of the pancreas. They decrease glucagon secretion. Then they improve sensitivity to insulin in the tissues to make sure that much of the insulin is being taken up by the tissues. Adverse effects. The adverse effects of sulfonylureas include the following. They lead to hypoglycemia. Then they can also lead to weight gain since there is increased uh, intake of the glucose of the glucose by the tissues, and additionally the fact that there is decreased uh, glucagon secretion, then that means that there will be enough glucose for it to be taken up by the tissues, and as a result the person will end up with a lot of leads to the weight gain. Contraindications that in people who have allergy to uh, antibiotics that will contain sulfonamides in them. So if someone has ever been given antibiotics that contain sulfonamides and the person reacted to them, then the person should not be given this kind of medication because they also contain sulfonamides and they will end up also reacting to them. So regulanids act in a way that they increase insulin secretion from the pancreas. They have shorter duration compared to sulfonylureas. So the sulfonylureas last longer than glanids in the body. The adverse effects here include headache, hypoglycemic effects, and weight gain. Why they have almost similar side effects with sulfonylureas. Why? Because both of them increase insulin secretion from the pancreas, and this will increase the uptake of glucose into the tissues, and as a result, and it means that they almost act in the similar way. That is why they have similar side effects. So the caution, uh, we do not need to use uh, sulfonylureas together with the glanids. So you decide to use one. Why? Because they have the same effect on the body. So you cannot use sulfonylureas and at the same time glanids. Why? Because they will overwhelm the body and give very severe side effects. Let us look at thiazole, uh, thiazolidinones, or what can be abbreviated as TZDs. So the mechanism of action of these drugs is to decrease insulin resistance, increase glucose uptake and use in skeletal muscles, then inhibit glucose and triglyceride production in the liver. So the adverse effects here include moderate weight gain, edema, hepatic toxicity. These drugs are contraindicated in black well, uh, in cases where people have exacerbation of heart failure. So when we talk about black box warning for exacerbation of heart failure, that means that there is a serious warning that if this drug is used, it will lead to exacerbations or exaggeration of heart failure. So if the person has problem with the heart, then the person is not allowed to use this kind of medication. Then alpha glucosidase inhibitors. The mechanism of action reversibly inhibit the enzyme alpha glucosidase in the small intestine. They result in delayed absorption of glucose. So the adverse effects include flatulence, diarrhea, abdominal pain. And one thing we need to be careful is we should know that they do not cause hypoglycemia or weight gain. So this is the good part of these drugs. The other type of drug is the dipeptidyl peptidase 4 inhibitors. So the mechanism of action here is they delay the breakdown of incretin hormones by inhibiting the enzyme DPP4. Then We should know that the incretin hormone increases the insulin synthesis and lower glucagon secretion. So what these drugs do is they delay the breakdown of this hormone to make sure that um, by inhibiting the enzyme DPP4 to make sure that the synthesis and the glucagon secretions are not affected. Then they also reduce fasting and postprandial glucose concentrations. So because of the fact that they delay the breakdown of incretin hormones, then they will lead to um, a reduction in the fasting and the postprandial glucose concentration. So when we talk about postprandial glucose concentration, we are referring to the glucose concentration after someone has taken meal. So the glucose concentration both when the person has stayed for long without meal or when the person has just taken meal are reduced, are minimized to make sure that there are no effects in the body. So the adverse effects of this medication is the upper respiratory tract infection can occur. Then the person can end up with headache and also diarrhea. Hypoglycemia can occur, especially when used with sulfonylurea. Let's look at injectable drugs. The examples here include amylin agonists, incretin mimetics. So both of these drugs aim to achieve normal blood glucose states, and the new injectable hypoglycemic drugs may complement insulin or other antidiabetic drugs to make sure that they produce better if one of them is pramlindine. So mechanism of action, these kind of drugs mimic the natural hormone amylin, which is secreted in response to food intake. So once the person takes in food, this hormone is always secreted. So they decrease postprandial glucose by slowing gastric emptying, suppressing glucagon secretion, and increasing satiety. So these drugs work by making sure that after the person has eaten food, the emptying of the stomach is slowed down. So in other words, they slow down the digestion of food in the stomach to make sure that not much glucose is released immediately when the person eats food. The usage, these drugs are used when other drugs have not achieved the adequate glucose control. When all the other drugs that we have talked about have not achieved adequate glucose. The adverse effects include nausea, vomiting, anorexia, and headache. So these drugs contraindications include avoid use with other preprandial, rapid or short-acting insulin products. So products that allow the insulin to be released very fast in the body, to act very fast, to allow faster in uptake of glucose by the body tissues should not be used together with these products. Otherwise, they will end up producing adverse side effects. Then the other drug is incretin mimetics. So the mechanism of action of these drugs, they mimic incretin hormones which are secreted in the GI tract in response to food intake. Uh, Stimulates insulin secretion, reduces postprandial glucagon production, slows gastric emptying, and increases satiety. So they reduce the digestion to make sure that when the person eats, the glucose is not released rapidly in high amounts. So they also create that feeling that the person is satisfied. So adverse effects of this drug include black box warning for the risk of developing thyroid C cell tumors. So when this drug is used, may result into someone developing thyroid C cell tumors. Has also some side effects like nausea, vomiting, diarrhea, rare pancreatitis, and weight loss. So the other one is sodium glucose co-transporter inhibitors, which can be abbreviated as SGLT2 inhibitors. So how do these ones work? They work by inhibiting uh, they work by decreasing blood glucose due to increased renal glucose excretion. Then they prevent glucose reabsorption in the proximal renal tubules, resulting in glycosuria. So because of the decreased reabsorption in the proximal renal tubules, there will be increased glucose in the urine, and this is what we term as glycosuria. Improves glycemic control, induces weight loss, and carries a low risk for hypoglycemia. So we still continue. They have effects of genitourinary system issues, UTIs, increased urination, and yeast infections. These are the major side effects or adverse effects of this medication, and this is because of the presence of glucose in the urine, which leads to much microorganisms multiplying in the urine, in the bladder, due to the fact that there are a lot of nutrients for them to feed on, hence leading to these conditions. Then also another adverse effect is the hypotension, fluid volume deficit, and the hyperkalemia. So interactions, this drug interacts with the rifampin, uh, rifampin. So when administered together, rifampin can decrease the efficacy of this drug and it ends up not working well in the body. Let's look at nursing considerations in the administration of antidiabetic drugs. So we need to assess the patient's blood glucose level before, during, and after therapy. Then we also monitor the patient's renal and hepatic function test, as some antidiabetic drugs may cause or worsen renal or hepatic impairment. Then also we need to educate the patient about the signs and symptoms of hypoglycemia and hyperglycemia and how to manage them. We need to advise the patient to follow a balanced diet, exercise regularly, and adhere to the prescribed medication regimen. We also need to instruct the patient to avoid alcohol, as it may result in increase in the risk of lactic acidosis with metformin, or glycosemia with sulfonylureas and meglitinides. So we need to advise the patient really to do away with the alcohol. Then teach the patient how to self-administer injectable antidiabetic drugs such as primulindide, exenatide, and liraglutide, and how to store and dispose of them properly. Then inform the patient about the possible adverse effects and drug interactions of antidiabetic drugs and when to seek medical attention. We need to encourage the patient to wear a medical alert bracelet which he can move with even in public, so that when he gets a problem, then the people around will be able to help, probably by checking for the antidiabetic drugs. If they are in the patient's bag, then they can be given to the patient. So that is all for today. Thank you so much for being part of this lecture, and may God bless you.